So you're telling me that you're going to add mass to my face and it's going to make things levitate or lift up by adding weight essentially to it. It's going to go up. Like, we know that's not true. If you have a sock and you put rocks in it, it's going to sink down, right? I'm not even anti-filler. Like, it's a bad thing. It just has to be used responsibly with the knowledge and understanding that this is essentially a permanent implant. It's not going to go away in 6 months. So that's a very dangerous mindset to have somebody injecting you thinking, oh, this is only going to last 6 months. That's wrong.
I'm Dr. Esra Çavuşoğlu, and I've been living a sober life for the past 18 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Finally, women who sent me messages regarding plastic surgery will find answers to all of their questions. In this enlightening episode of Soberhead Podcast, I have Dr. Cameron Chesnut, a leading facial plastic surgeon who specializes in regenerative medicine and holistic wellness. Dr. Chesnut shares his innovative approaches to surgery and recovery, focusing on techniques that prioritize the overall well-being of his patients. This episode dives deep into the intersection of health, wellness, and aesthetic surgery, offering listeners a comprehensive look at how modern medicine can blend with holistic practices to enhance both beauty and health. Now, let's go to the episode. Here is something that is fascinating. A huge amount of people who watch this channel frequently are not subscribed. So I want to ask you a quick favor. When you subscribe, it helps us to make the show better, access to the world-leading experts, and ultimately bring you more value. All that I ask is for you to hit the subscribe button, and in return, I promise we will make Ayık Kafa better every day. Welcome to Soberhead, Dr. Cameron Chesnut. I was waiting for this moment, and the reason I'm so excited because, I'm a woman. Also, I'm from Turkey. It's kind of like Los Angeles, I want to say. Istanbul is more like Los Angeles, that people like to do some work on their face, whether a plastic surgery, fillers, Botox, name it. We have it a lot. And lately, obviously, with reality shows, they're going to be a prototype of faces that young people would like to imitate in a way. I had a lot of requests from my audience. They wanted me to speak with a plastic surgeon. There are multiple reasons I wanted to talk to you, but one of the reasons is that, whomever I would pick from Turkey, they would have some dead body behind. You know what I mean? So I wouldn't be able to pick the best one and then suddenly someone else from Turkey, oh, this guy messed it up my face. It's unfortunately, you use your hands, sometimes things doesn't go well. Even like very famous doctors in the United States, we know that they leave quite a bit of a injury behind. But let me just say that you're a plastic surgeon, you're an athlete yourself.
Absolutely.
You're a fellow biohacker, and you have an interesting way, not interesting, actually an amazing way approaching how you're prepping yourself for your surgeries. So many things that you're juggling. Again, like I see that you're a great skier. You love snow. I do love it as well. Welcome to the podcast. And what made you interested into this plastic surgery?
Thanks for having me on. And that was a really nice intro. I'm a facial plastic surgeon, just to be a little bit more specific. Sure. I only really do work on the face. I don't do body things. That just aligns with my, sort of deep dive in a very small area. And my patients travel to me from all over the world. I have patients from Turkey, from the UK, from really all over. That fits in a lot with what you're talking about. It tends to be people who resonate with that idea of being an athlete or being a biohacker. And like you said, there's a big part of preparation for surgery, not just for me, but for my patients themselves. And then there's this idea of recovering afterwards, which is huge, massive. What does that recovery period look like? How are we optimizing it? And then how are we integrating some of those tools from regenerative medicine or biohacking or functional medicine and longevity? How are we making those things benefit our surgical recovery, which is really nice because we get better faster just from an experience and a time frame standpoint. But the real benefit comes in better results in the long term as well. And that's one of the big differentiators. That's why people are traveling from all over the world is because, like you said, they want the best results. And that comes with knowing that who you're working with is consistent and you can see what they deliver. And, you're not having those disasters, sort of like you were talking about. Yeah.
So how did you get into this field?
When you're going through medical school, you go into it and you don't really know exactly what you're going to get to do or want to do. It's a very broad field. And for me, it really goes back to my roots and my core, the core person that I am with my values and things that kind of bring me fulfillment. And that's a lot of creativity and 3D, three-dimensional spatial types of awareness. And when you get into medicine, there's very narrow windows for that, but they tend to come in things that are more procedural or surgical, like even orthopedic surgery on the bones is very three-dimensional. It's almost like carpentry at that point. But something like plastic surgery affords a little bit more room for creativity and problem solving. And that's how I found my way there ultimately. And then within that, like you said, then just your personality starts to come out a little bit and those unique things about you, which for me is heavily rooted in athletics. And it's a pretty interesting alloy of those things of creativity, three-dimensional cosmetic types of things, and bringing in sports and biohacking, things like that.
Were you a professional athlete?
Yeah, I competed at that level in the past. In the United States, I was a Division I collegiate athlete, and then afterwards, I was a high-level athlete racing in triathlons and Ironman triathlons, and that's sort of how I put myself through medical school financially. Yeah, so I have definitely that mindset, all the things that come with that, the discipline, the preparation, the ability to go to uncomfortable places and grow out of them.
You already a couple of times mentioned facial plastic surgery. When you were talking about like how the patient prepped themselves and the healing part, obviously I had my share in small surgical things, not like a big full-on facelift. People around me had, from really, really high-end surgeons in New York and stuff. None of them, neither of us, went through any prep. Maybe do not have blood thinner or omega-6 or 3, whatever. It's do not take aspirin or Tylenol. That's it. And you're talking about a whole journey. And what do you expect them to do? What do you do? And what's the outcome? Why do you do it?
Yeah, great question. And it is a very different mindset than you'll find anywhere in other surgical practices, because, we're talking about facial plastic surgery for me, but it's not unique to this. Anybody who's having any surgery of any kind can benefit from this mindset. And like I said, coming at it with this idea, approaching it as an athlete, we were kind of talking offline before, I'm looking at it as though my patient has an event coming up and we know that there's going to be an injury in that event. They have to heal from something. And so we have all this prep time to have them optimized and as ready as they can possibly be going into that. And so that means everything from their baseline nutritional status and micronutrient status all the way through their inflammatory profiles. We are trying to optimize those things going into surgery. I don't want my patients coming into surgery inflamed and having, been eating processed foods and, a bunch of sugar and things like that. Very basic things that a lot of my patients are already doing because that's how they're finding me. They're already sort of maybe into their health, longevity, wellness. But we know that those are wildly beneficial going into surgery. Even something like, this is huge in all surgical specialties. We know that a patient's vitamin D status going into surgery, where their baseline vitamin D levels is so strongly predictive of their post-operative infection risk, which is just a link to their immune system, right? So we have these vitamins, these micronutrients, we have inflammatory profiles. So then I really work to get my patients sort of cardio-metabolically ready. And because again, you're going to be down for a bit after this. If you're a really high-functioning, high-level active person, we know that there's going to be some reduction in your activity.
Let me dive in there because, I think one of the reasons, at least for me, that I keep pushing things, I know that my life is going to be really getting interrupted.
Correct.
As a woman, whomever says they don't have, all women have body dysmorphia, period. They all have, they think that they need to work out all the time. They kind of limit what they eat. And then just thinking oh, you cannot do any workout for 2 months. That's oh my God, what am I going to look like? And what do you ask them to do beforehand then?
This is where, getting into the actual portion, leading into surgery, I want to we go through knowing, okay, here's what your post-operative period is going to look like. Because as you mentioned, especially with my group of patients, they are very high achieving patients. They're very into their health and longevity. And we know, okay, for 2 weeks after surgery, you're just going to be walking, say. You can do all the movement you want, but you're not going to be able to lift weights and things like that. And then we get into what happens at 3, 4, 5, 6. So we have this runway of what we know it's going to look like afterwards. So that means that I tell my patients to treat this like a planned recovery period in their normal training cycles. So we know that there's going to be some extra physiologic stress placed because of the healing from the surgery, but we're also going to have a lot of beneficial modalities like hyperbaric oxygen, PEMF, IV nutrition, things like that. They're going to happen as part of our postoperative protocol that they can use to help their training recovery leading into it. So it would be just like with you, Ezra, if we were saying like you have 2 weeks where you just are only going to be able to walk. You would really get after it leading into that physically, knowing that you're going to have that planned break coming up. So we take that kind of approach, which is also really then beneficial, again, from a cardiometabolic standpoint for the actual physiology of their healing from the surgery, because that's the unique part, that we have this other stress that we're placing on them. We're placing it on their immune system. We're placing it on all parts of their ability to heal from this injury or from the surgery, paired with a rest period. And so, in addition to all the nutritional and micronutrient things, we are getting them, I'm even like advising my patients on what types of cleaners they're using in their house to try to reduce their inflammatory burden leading into it. And then right before surgery, we really start to focus on, and by right before, I mean in a couple of weeks before, we start to focus on like a peptide regimen to get them ready and mobilizing their intrinsic stem cells, which we do with some supplementation and then with some things like hyperbaric oxygen before their surgery. There's a lot of these little tools that go into, again, getting them ready for a known time frame where they're going to have to recover.
And then after also, I think they stay with you for a week or more.
Correct.
Yeah. First, please tell me, what are you guys doing after the surgery? And also, if one does all these, how much it shortened the recovery time?
Yeah, quite. That's a great question. So my patients are traveling, so they are staying with me for roughly a week afterwards. And in that week, depending on the procedure they have, depending on what we have and know about that patient, they have a protocol that I'm putting them through that is heavily rooted in some of these biohacking types of modalities. For example, they're getting hyperbaric oxygen treatment every day, and that is probably the most important of the things that we'll talk about. And there's a bunch of nuances that go into how that's best for in a postoperative situation. They're getting IV nutrition postoperatively because the day of surgery, the day they've been fasting, they're not, eating, their gut inflammation gets disrupted from the procedure and the inflammation of the surgery. And so in the immediate postoperative period, we're just getting around those issues and going right with direct delivery through an IV. And even better, if we have the genetic profiling of my patients before they come in, if they've been through sort of a functional medicine protocol with us, then we know their genetic predispositions, their nutrigenomics, and we can customize that IV nutrition postoperatively to be very specific to them and to the procedure that they've had. And then after that, they're going to be getting things like pulsed electromagnetic fields, which is going to help their extracellular matrix healing, increase blood flow, decrease discomfort afterwards, which is a whole nother, subtopic. We're doing light-based therapy, that's just photobiomodulation with a lot of red light, but I'm also using some blue light and things like that. That really is important for the surface changes. With a lot of my surgeries, I'm also treating the skin simultaneously at the same time. That may be with a laser cocktail, I call it, like a version of a laser resurfacing. And so we're optimizing that as well. Then, of course, just a post-operative supplementation protocol that is sort of part of this package. So from a patient standpoint, experientially, you travel in to see me. We have a lot of pre-things that we're doing, say, the day before surgery. And then after your surgery, that week is very busy. You are very proactive. It's very different than what people are used to, where they kind of go sit at home and just wonder if everything is normal and okay and what's happening. This is very different. It's very hands-on.
Actually, I was thinking when you were counting all these, it's like almost a wellness spa. And then it's like the best time to do all these things, bazillion things, because that's the week that you kind of do nothing and you sit and you're bored and you just you're in pain and you're frustrated. You cannot go in public, all this stuff.
Right, exactly. And so it turns into a very sort of hands-on, you're with our staff, you're with myself, my fellows, our nursing staff that whole week. And, it's very normal in that week to be having questions too about, is this swelling normal? Should this be happening? And those are all very natural questions. And it's just really nice too, just from a direct relationship standpoint, that you're very present and with us that entire time. That occupies most of your day in the postoperative period. It may be a 4 to 5 hour ordeal that you're with us that day in a very positive way. And, it kind of keeps you from getting bored and sitting at home by yourself. And, the night after surgery, my staff is going home with you after your procedure to, stay with you and make sure that you're getting, we set you up with where to stay, but that you're getting there and you're getting back. And it's a very hands-on type of experience to do it.
And when they do this compared to not doing with other surgeons, what's the difference of the healing period?
That's a super great question. And I work really hard to pay attention to this, but it's difficult to quantify exactly, correct? But in my experience, more than a decade of seeing what patients look like pre and post-operatively, including, trying to control for the procedure, the age of the patient, the prior procedures they may have had, if they've had filler, things like that. I would say that most people after that week or 8 days, 7 to 9 days, call it that they're with us, are at about what would typically be a 3 or 4 week mark from swelling, redness, inflammation. Yeah, well, that first week is really where all the benefit happens, because the first 4, 5, 6 days, and this is physiology. This is looking at literally what our wound healing phases or wound healing curve looks like. There's all these changes from inflammatory phases to proliferative phases, and all that's happening while you're with me and present. And so we can really, on those key phases of inflammation and proliferation of making new blood vessels, we can be there to support that process and optimize the way that it's going down so it happens more efficiently. And again, this is where, interestingly, if we look ahead 6 months down the road at the trajectory of the final results, they are better, and evidence backs that up. We know that these procedures, the results are better by aggressively pursuing or proactively pursuing recovery in that first week.
But also, besides that, you have a couple of more very special approaches. One is you do not use, if I'm not mistaken, any anesthesia or narcotic painkillers. Another
That's
thing
correct.
is that you're not stuck with just one type of approach. It's like, there's, you see now everyone is doing deep plane. And then a couple of them do extended deep plane. Like you don't hear anything else. It used to be before, like you would see the lips going sideways. Now it's just something else. But how you're describing is like, my goal is not to make you, when you're, let's say, 60, 40. My goal is to make you look a good 60.
Right. I think there's two really important keys here. The first one you mentioned was sort of about anesthesia and pain control. That was a good point. You brought it before about being uncomfortable in that week. And from an anesthesia standpoint, you're right. I do not use general anesthesia for this. I'm not intubating you and pushing you. I like this analogy of like pushing you to the bottom of the ocean and then trying to keep you alive while we're doing our surgery, because that we know leads to long-term cognitive decline and issues. It's hard on your brain, if you will. In addition to a really bad postoperative experience for a lot of patients where we know that you're foggy in your brain and you have nausea and vomiting. It's unpleasant, right? So I'm using IV sedation for this. And that IV sedation is very cognizant of this being an elective procedure, right? We're doing this by choice for cosmetic reasons. I do not want to change my patient's long-term neurocognitive function. I don't care if it shows up 20 years down the road. I do not want to have any hit to what's happening with their cognitive function. And so with that IV anesthesia, I'm taking my patients, and instead of pushing them to the bottom of the ocean, I'm kind of just getting them just underwater. So they're just asleep, basically. And while they're in that sleep phase, I'm not using any narcotic or opioid medications at all for pain control. And I'm also not using any benzodiazepine medications for that. And again, this is all based off of the interactions of those drugs long-term with what they do to our brain. Instead, I am using consciousness controlling medications that are pushing, again, just under the water. And then all the pain control is actually done with local anesthesia, nerve blocks, things like that. And so there's no pain, no stimulus being delivered, and you're just barely asleep. And what that means is when we're done with our surgery, we wake up very quickly without a fog. We can carry on a conversation after surgery very shortly that you will remember. You don't have the nausea and vomiting. It's just a very pleasant postoperative experience. But the important part of that you mentioned too is the pain control afterwards. So the last thing I do in the procedure is use a long-acting nerve block. Right when we're done, everything's over. You're still numb from the procedure itself. And that nerve block lasts 48 to 72 hours after the procedure.
Wow.
So now instead of having that, usually it's at about in the first 24 hours, there's quite a bit of discomfort after surgery. We are bridging through that time frame where there's normally discomfort in a way that doesn't really require having another way to block it because the sensations are never sent in the first place because of those nerve blocks. So it's very simple, very safe, avoids needing opioid pain medications, which means you're thinking more clearly. You can go to the bathroom, again, a better postoperative experience, and you're not having a bunch of discomfort that you're having to battle through with that. So it's a very unique way to approach it, and just tends to be, again, a much better overall experience afterwards. And then, again, thinking way down the road, we're not blunting any cognition with that for this elective procedure.
We were saying that your approach also, how you take a face, look at a face, and then deciding what to do is really personalized.
Absolutely. Yeah. And so I work with younger patients on the spectrum as well versus older patients. And like you said, when I'm saying younger, I'm saying patients in their 40s or early 50s. When they come in to talk about a lifting procedure, say, that should not be the same procedure that you're talking about with somebody who's 59 or 65. It's a whole different place on the aging curve at that point. And so a deep plane extended facelift or a deep plane facelift for somebody in their 40s, in my opinion, is crazy. It's asinine. It's over the top. They don't need that type of a procedure. We do still want to have durable results and we want to get the results that they're after, but there's other ways to approach that. And a prime example of this would be, somebody who's 47 years old and has legitimate early signs of aging and gravitational changes along their jawline, and they want to have, or 45 years old, say, and they want to have a lifting procedure because this is bothering them. Well, to place the traditional incisions around the ears of a full-blown deep plane facelift is a travesty for that person. It's too much. There's too many long-term issues to justify the amount of correction that they're going to get. Instead, I'll approach that with a small incision hidden back in the hairline, and I will access the same exact deep plane that I would have accessed from the ear, and I will be able to lift and elevate from higher away in a hidden, we call it an invisible access point, and be able to get the gravitational correction that 40-something-year-old needs and not have to place the incisions around the ear. So it's very customized to where they're at that point in time, but it's still hitting their metrics of success, going after the areas that they're after. There very much should not be a one-size-fits-all approach. And I think that saying that out loud sounds cliche, but unfortunately, it's commonly approached that way. That this is the procedure when there's, gravitational change.
So question, how do you do it? Don't you take any skin if you're doing?
Not always. And so that would be a great question because that's the limitation. If, let's say on the other end of the spectrum, let's say you're 65 years old and you have laxity and a bunch of extra skin, using this access point to access that, I can't remove as much of that extra skin or get as much gravitational change as you need there. So it's a degree of improvement, but that degree of improvement may not be as much as we want to achieve our end results, which is why it's very, very customized along the spectrum. If you're 40-something years old, the amount of lift that we can get from this area is probably about the amount you need. That's a good thing. No access around the ears. But if you're way further down the aging curve, it's not going to be powerful enough to move the needle for you.
Because I did enough investigation for me, for people around me. So how do you do it? Do you just have a hook and just pull it?
Yeah. So this...
Because I think nobody asked you that detailed question.
Yeah, this mindset applies to upper and lower eyelid surgeries and everywhere. But the facelift idea is a really great one, right? Because generally people are noticing laxity around their mouth and the bottom of their face as a prime example.
Sure.
Different when you're 45 than when you're 65, but it's present in both, right? And so, again, the traditional approach is to make incisions around and behind the ear and to get into the deep plane and to elevate those fat pads back into their place. Even that is a very progressive and innovative approach compared to what is performed 90% of the time, which is basically a skin or superficial-based procedure where people just cut out skin and pull. That is ripe for failure because our skin is not that strong. Pulling on the skin to get a facelift is going to fail, and it's going to make you look overly tight on the surface with everything underneath still sticking. That is what we think of when we think of a bad facelift. When we see people who look like they're in a wind tunnel, you talked about the corners of the mouth moving.
Yeah.
That's what that results from, right? So now we switched from that normal every day that's happening, thousands of times around the world today to switch into a deep plane, right? And that's a very progressive, that's actually going under the fat pads, lifting them back up. Wonderful, beautiful procedure, which is fantastic. But when you're 45, that's a lot of invasiveness for what it's accomplishing. Mm-hmm. So accessing from the temple, I'm working through the tissue planes to get into the exact same deep plane, but I don't need incisions around the ears to get to it. I'm accessing it from above. Once we're in the face, it is quite literally the same space that I would be in if I made incisions around the ears. I just haven't dissected and freed up everything in front of the face. So that doesn't allow skin to be removed as readily, but it does allow me to get underneath those same fat pads, underneath the same musculature, and re-lift them to the same place. This is the paradigm all over the face, is I'm really looking at where fat pads used to live, where they've moved down to, and I'm just refixing them back in the home that they were meant to be in. And that's exactly what I'm doing through the temple in those areas, is just finding the fat pads, moving them back, and fixing them there.
I understand now. So there's not much skin needed to be cut out. Therefore, you do the same. What do you do then, suddenly you hit a filler?
Right.
That's more laparoscopic. And, when you cut open, probably it's easier to clean them.
Yeah, so that's a great question. This gets into a whole nother topic of
We're going to get there. Yeah, that was going to be my second thing.
Yeah, it's almost universal that I see fillers. My patients have had prior filler, anybody who's having surgery. And, it's not necessarily a bad thing at all. And it makes sense, right? Fillers are marketed and position themselves as like the first step in the anti-aging process. They're relatively approachable. They're relatively inexpensive. Like all of them make a very natural first step to go. And they can, or volume can have a benefit to the aging process early on. The issue with fillers has become, for most people, they're a small part of the overall aging process. If there's gravitational change, there's often a little bit of volume change in there as well. There's qualitative change to the skin. All of these things go together. But for most people, their only strategy is using filler and Botox or some equivalent to address it. So you're taking what's 15% of the problem and blitzing it with 100% of your effort, and it gets overdone. And we see that all the time. This is prevalent everywhere, from Turkey to California to everywhere in between, right?
Sure.
And it's just a misguided strategy driven by this idea that they're so easy to get into. And the people that do them, that's often the only thing they do. They have filler and that's the roof, that's their ceiling. They don't offer surgery. And so they'll just keep filling and filling and filling. And it also has this idea that, filler lasts 6 months or a year or 18 months or 24 months. And we know without question that that is not true. Fillers last years, decades. They do not go away. They migrate around, then they break down and they change. But the actual hyaluronic acid parts of those fillers is not gone. It's just redistributed itself throughout the face. And so this paradigm of topping it off every 6 months just starts to diffuse and fill the face and becomes very problematic when we look at the long term, right? And you mentioned this idea when we were first starting of seeing somebody and really kind of like grabbing onto that image and wanting to mimic it, right? That can be problematic because it changes your perception of yourself. And fillers do this very well because you get your filler, you change a little bit. And over the next 6 months to a year, your perception of yourself drifts over to that as your new norm. And then you get filler again, and your perception drifts over here. And that keeps happening slowly over time. And the next thing you know, you are way over here from where you started, but it happens so insidiously and slowly over that time frame that you look nothing like your baseline anymore. But you're not picking that up or recognizing it. That's this idea called perception drift. And it's really common in the filler world and leads to distorted faces in the long run, really.
What do you mean it never goes away and it keeps migrating to other places? That's scary.
Yeah, there's lots of different types of filler, but predominantly here I'm talking about these hyaluronic acid fillers. These are the most common, the most prevalent, the most inexpensive. They're everywhere. They are molecules of hyaluronic acid, which is a normal part of our skin, the extracellular matrix of our skin outside of the cells that holds on to fluid. That's what its purpose is in normal skin, is for this hyaluronic acid molecule to grab fluid. It's called a glycosaminoglycan. And so, the filler world takes those hyaluronic acid molecules and it manufactures them in a laboratory to be, as close to identical to our own as it can. And then it cross-links it together to make these different gels. And the gels have different, for lack of a better term, hardnesses or different properties to them, how flexible they are, how firm they are, whatever it may be. And these get turned into these injectable treatments. So those get injected into the face, and our face is ripe with blood vessels and musculature. You can't avoid those things when you put it in. And so it's getting all over the different fat pads and muscles of our face. And over time, the cross-links that hold those molecules together break down. And so the filler itself becomes more mobile and moves through the muscles. It's this idea of, if I were to put a lump of gel in your bicep and you went and did curls or pull-ups or something, that gel is going to migrate as the muscle contracts over and over again. It's no different in our face. We're removing our facial musculature. It's the gel starts to redistribute and move throughout the muscles, especially in our lips or especially around our eyes. This is where we see it the most commonly. And it has now moved away from where it was initially placed, which gets interpreted as the filler is gone. Well, it's not gone. It's not just left and went to a different place. And so then you put more and it moves, and you put more and it moves. And that's how we get this sort of like long-term distortion. So I see this surgically every single surgery that I do, because I'm working in those spaces where the filler was placed, and it is sort of everywhere. And our body responds to it in different ways. Sometimes the filler just looks like wet sugar. There's not a lot of reaction around it. It's just sort of sitting in these tissue planes, attracting water to itself. Other times our body has mounted an inflammatory or a foreign body response to the filler, and it starts to try to wall it off or create an almost like an implant, like a breast implant would look, with a little capsule around it in the soft tissues of our face. And then sometimes it's just frankly inflamed in those areas. And a lot of people that have had filler have experienced this. When you get filler in your face and things go fine, and then, a year or two down the road, or whatever time, 8 years down the road, you get a cold, like a common cold, a virus. You get a vaccination. You get your teeth cleaned, something that causes a systemic inflammatory reaction, and your body goes to the filler and recognizes the filler, and your filler gets red, swollen, tender, like kind of a little uncomfortable. It happens very, very commonly that people will notice that, especially along their cheekbones and under their eyes, where it hurts for that period of time. Like, wow. And a lot of people, honestly, I don't even think register what that is. But when they really think back, they're like, oh, I had filler here 4 years ago, and I got a cold, and I got swollen under my eyes, and it was hurting. Well, that's from your filler getting inflamed. So we know that our immune system recognizes it for long periods of time and is trying to get rid of this foreign body that's there.
So then what do you do? You said that most women, if not all, have some sort of fillers.
Yep.
I mean, in order to give them a great facelift, what do you do? Like, you clean them, you melt them?
Yep. There's a spectrum of the way that I think about filler when I'm managing it around surgery. And this is something that I lecture about on the international level. Like, how do we manage filler around surgery? On one end of the spectrum, I have patients coming to me where their main objective is filler-based. They've gotten perception drift. They're too far into it. Their face is distorted. And our main objective is we need to get rid of this filler. So you can do that surgically. You can do that with an enzyme that dissolves the filler, and that hyaluronic acid gets dissolved by an enzyme called hyaluronidase. And it's very specific to dissolve hyaluronic acid, and it works, but it's not.
But I heard that it also melts your own fat.
Right. Well, like I said, we have native hyaluronic acid in our extracellular matrix. And so that when we put in this enzyme, it does not know the difference between the filler and our native hyaluronic acid. So you're exactly right. It is not an ideal way to get rid of filler. It does work. It does address the filler. It does break it down, but it doesn't get rid of all of it. And it does have effects on our normal hyaluronic acid. What you're hitting at here, Esra, is a very loaded, hot, controversial topic in injectables in the filler world. When I say that I see situations of this hyaluronidase enzyme affecting our native facial fat or native facial structure, let's just say that a little bit more broadly, people go crazy and injectors argue, and it's a very protective world where people are very narrow-minded to think like there's no way that this affects our face, and our face, if it does, our face recovers. And I've just seen too many times, including actually on my Instagram, if you go look at it, I just saw a 22-year-old girl from Peru whose face was essentially destroyed by this enzyme. It wasn't egregiously or really crazy overused. It was just being used very frequently. She's 22 years old. She's beautiful. It undoubtedly changed her face afterwards to a degree that you cannot argue with. And so that doesn't happen every time it's used. It doesn't happen to everybody. And there's some predictors of maybe who that might happen to. But all that to say is that this enzyme is very specific for hyaluronic acid. It can improve and get rid of filler, but we have to be more thoughtful about it than just using it without considering the other effects that it can have. And so when we have that person who has a frank problem, like a very blatant problem from their filler, dissolving is not the only and best option for them. It's often being paired with this surgical idea of manually removing as much filler as we can. And we're doing that. I'm trying to approach it as minimal of an access as I can.
I cannot even wrap my mind around. Let's say that they have something under their eyes, like an area that the cheek is meeting the nose. How the heck you get in there without like cutting in the middle of the face?
That's the perfect example. Perfect example. Under the eyes and the cheeks. Swollen. There's like a bag that exists. There's a bluish coloration from this filler. We see it all the time. Like, it gets swollen and goes down. There's this big gap in their cheek now. Really common situation under the eyes. So to get that filler, I will go through the inside of the eye. So no external cuts, no incisions. And I can go to the fat pads and I can go to the muscle and I can essentially scoop or clean the filler out of there as much as I can get in that way. And I use this analogy of it's like walking into your bedroom or your living room where you have shag thick carpet and there's this big pile of wet sand sitting on this carpet, right? And it's like, it's everywhere. And the first thing that you do is you take a shovel to it and you start scooping the sand out so that you get as much of it out that way as you can. But you know that the shovel's never going to get rid of all of the sand because some of it's down on the carpet too. That's how I approach this, where I'm getting rid of as much of it manually as I can, scooping it out, shoveling it out. And then whatever's left after that's done, then I'll take very focal, small amounts of that enzyme and put it right exactly in the spots that it needs to go because I'm looking at it. And like I said, when I see the filler, it comes in many different forms.
How do you see the filler, in the eye?
I can see it with my loupes on. Yeah, exactly. With my magnifiers on in surgery. And it's not difficult to tell. I mean, it's not that small or hidden. You can see it with your naked eye. And as I'm removing it, I can tell, again, if it's just sitting there as it was injected, or if it's been encapsulated. All of these change the process of getting rid of that filler. And so, that can be a focus of some surgeries, is just let's get the filler out. And then while I'm there getting the filler out, I will also do the little anatomic rearrangements that I kind of say the reason they got the filler in the first place. Like if you got filler under your eyes, it's likely because you had eye bags or had tear troughs. And so in addition to getting rid of the problematic filler, I'm also going to fix the underlying issue that led you to get this in the first place. So that's on this extreme end of the spectrum. Most people fall where they have filler. It's not ideal. It's not perfect, but it's also not like grossly problematic. It's just kind of not great. And so we're doing their surgery. And in that sense, it shifts the other way where I'm really focusing on, okay, let's do our lifting procedure. Let's do our eyelid surgery. Let's make sure that we're getting our anatomy correct. And while I'm there, I will manage the suboptimal filler and I'll remove it and I'll usually replace the parts of it that are important because, some of those fat pad volumes we want to be, optimized, and I'll replace the filler with your own fat transfer. And we kind of move through it in that direction. That's significantly more common of a way to approach it, which is a little bit more hybrid of let's do the underlying surgery that we want to do anyway. And while we're there, we'll optimize the filler that's present.
Do you ever use the enzyme without doing a filler removing surgery or a plastic surgery?
Yeah, so when I'm using the enzyme by itself, I'm usually guiding that with an ultrasound and kind of looking for the filler and going directly to it. The problem is the resolution of the ultrasound is so low that it can only show me like kind of balls or big groups of the filler. And as I've seen in surgery just thousands of times, it's very rarely in these big groups. It's often distributed and it's very thin. Like I said, it's like you sprinkled sugar in there. And so ultrasound's not going to pick up those little fine granules of it that same way. And so you can do that and you can approach it that way, but I like to, because I'm predominantly doing surgery, I like to approach from the manual removal first. That's my first goal, is to get as much out as I can by scooping it out, if you will. And on the second goal would then be, okay, now what's left behind? Now we'll use the enzyme. Very similar to that, sand on your carpet analogy. I'm not going to go vacuum the big pile of sand until I've scooped off as much as I can.
What makes a surgery, I know that what makes it very easy now, so no filler is like very good prep, but what makes it very difficult? Because, our mutual friend Amitai, and he often says that, these very strong laser treatment like radiofrequency and whatnot is really reducing the quality of the skin.
Yeah.
Are you with that?
Well, I think that there's a spectrum here, like with many things. I don't love the absolutes of always and never, and I think very few things exist on that. But this is a great question, because let's say somebody is 53 years old, they're coming, let's just keep talking about facelifts because we're on that, or eyelid surgeries or whatever it is, but they've never done anything at all. When I go to do that surgery, the areas that I'm working are very specific and planned out. We call them embryonic fusion planes. I'm in areas that, as we were forming as embryos, fuse together. And so because of that, they are very easy to separate. There's no blood vessels in there. We call them surgical planes. They're almost like meant to have surgery in them, right? Things are very straightforward. It separates nicely. Things move really well. Beautiful, wonderful. When you get facile and good at surgery, this is like our dream, right? We get into these spaces and do our thing. Well, that changes a lot when there have been injectable treatments, and not just in this case hyaluronic acid fillers, but that gets into some of these other types of fillers that we would call like biostimulants, where you inject them and the goal is to stimulate collagen, say. The issue with that is stimulating collagen creates an inflammatory response where our body recognizes a foreign body and builds a capsule around it. Well, that capsule is made out of collagen. This is a biostimulating, collagen-stimulating treatment that people use for aesthetic reasons, but it's essentially causing scarring, fibrosis, binding, whatever we want to call it, in the area that it's injected. So now that gets injected into these tissue planes, and they get sort of welded or glued together. So instead of being able to take the pages of a book and just flip through them and have them open up nicely, it's like somebody dipped the book in glue, and it's like, okay, now turn through the pages. It's a little bit more challenging to do that. Devices, let's just say the word devices, because that it can include lasers, radiofrequency microneedling, all these things. Those cause an inflammatory response in an attempt to build collagen as well. And sometimes that can be a good thing, especially when used well in a more superficial plane where it's targeting the actual skin itself. Our skin is loaded and ripe with stem cells and an ability to heal. It's our external barrier to the world. It's really good at healing. And so we can give it a little bit of a purposeful injury, especially if we're using some help with regenerative medicine afterwards. And we can sort of use that healing response or manipulate or optimize that healing response to get a benefit, more elastin, more collagen, things like that. The issue is that gets taken deeper down underneath the surface of our skin, and people are trying to lift or tighten with these devices, and they're going down to the musculature and the fat pads, which do not respond the same way that our skin does. They don't have the same healing capacity of our skin. And so now when they get damaged, they scar down and they change volume and they change their consistency. And that makes surgery very difficult for me. It also changes the microvascular circulation in those areas because they're more scarred and fibrotic and firm. They don't have the same blood flow, essentially. And so they don't heal as well or as quickly afterwards. And so very commonly, postoperatively, we're managing those differences in the healing process in somebody who's had a lot of filler or a lot of devices or whatever it may be. And that's where my postoperative protocol that we talked about way earlier becomes very important, because now hyperbaric oxygen is wildly important to our long-term success, but also that immediate recovery period where we know blood flow is not as good.
What I'm hearing is that if someone is considering at some point in their life a plastic surgery, it's better to stay kind of as much as you can. I know that people would want to push the surgery as much as they can. But, all these things, or you have to pick a path that, I'm just going to do all these, medical aesthetic stuff, fillers, Botox, lasers. They came up with new laser treatments now. It takes like a piece of a skin out. I forgot the name.
Yep.
Elacure.
Yeah, that's called Elacure.
Yeah,
yep.
Elacure. Because I only can think, based on all the things that you're telling me, that, Elacure also like damaging the skin pretty much. Even it's getting in, taking something out. It just like messes up with the whole nature of that skin.
Yeah, and it goes back to what I was talking about before, where, the idea of doing a facelift by just removing skin is going to fail. That's not a long-term strategy that's actually going to be beneficial. And, I think if I were to really try to make it as simple as I can with somebody who's going through the aging process, is that I would just be very cautious with the non-surgical treatments. And if we really just put our common sense thinking cap on, when those things sound too good to be true, we sort of have to, hear that and listen to ourselves there a little bit, where, the idea that filler is going to lift things up. When we really think about that, we're saying, so you're telling me that you're going to add mass to my face and it's going to make things levitate or lift up by adding weight essentially to it. It's going to go up. Like, we know that's not true. If you have a sock and you put rocks in it, it's going to sink down, right? If you have a breast and you put a breast implant in it, it's going to project differently, but overall that breast is going to sink more over time. We know that. It's got more weight and stress on our soft tissues, no question about it, right? So it's the same in our face. So, I'm not even anti-filler, like it's a bad thing. It just has to be used responsibly with the knowledge and understanding that this is essentially a permanent implant. It's not going to go away in 6 months. So that's a very dangerous mindset to have somebody injecting you thinking, oh, this is only going to last 6 months. That's wrong. And so if they're approaching it with a 6-month, strategy and it's going to be there forever, you could see how that become problematic. With the devices, it's the same thing. Like, devices aren't inherently bad. They can be really helpful, especially when we're focusing on the superficial surface of our skin. I use devices. Like I said, I use my laser cocktail during surgery because surgery is not addressing the qualitative aspects of the surface of our skin. I need another tool to address just the quality of what's on the envelope, on the surface. So that's not a bad thing. But when those devices are promised to lift or tighten or kind of replace a facelift, say, that's really common, that's when you should be like running away. Don't walk. We know that that's not going to happen. And that's where damage starts to, enter the process a little bit. Not only is it not going to work, if we're lucky, it just doesn't work and you wasted money. But on the other end is it could cause damage to the deeper structures of your skin and potentially at least make more difficult what ultimately you're going to do with a surgical procedure someday.
Cameron, one very short question around Botox. Everybody knows about Botox, so we don't need to talk about Botox. But I had a session with Adil Khan about the stem cells that I know you use it as well. And what he says is that in order to help the muscles above the eyebrows to go back to the old function, let's say. He says they're using stem cell injected into these areas so that starts lifting the brows. Is that a valid thing?
So what Adil's talking about there, Dr. Khan, is Botox is essentially we call it a chemical denervation. It uses the chemical structure to make it so that the nerve doesn't communicate with the muscle. So there's just no communication between them. And so just like any muscle that isn't innervated, that muscle will change and atrophy and get smaller and not be as strong afterwards. Now, Botox truly is temporary. It's not a permanent denervation. Eventually, the chemicals start to communicate again. It's acetylcholine, and it causes that muscle to start contracting again. But when that repeatedly happens, or when somebody's on a Botox cycle where they never really let the muscle kind of get a stimulus again, the muscle changes structure. It would be just like somebody with a spinal cord injury and they have, a change in the musculature of their legs. And then all of a sudden they get reinnervated and, they're not going to be walking the next day. It takes some time for that to rebuild. So it's the same in our forehead or any of our muscles of facial expression. And so, yes, stem cell-based treatment can certainly help the regeneration and re-strengthening of that muscle. It's not unique to Botox in our forehead. That would be any muscle that loses its nerve signal, atrophies, and then gets its signal back again. It's just helping it recover a little bit. And eventually, likely it would recover, especially, let's say we're talking about focused rehabilitation and things like that, but people are not doing that on their forehead. Total side note to that is you're going to get other benefits from those stem cells in that region as well. Like you said, I'm using stem cells intraoperatively. I'm using them postoperatively. They're magnets to the inflammatory reactions that are happening. These are good, inflammatory reactions, but they're really helping orchestrate that healing afterwards. And so again, I think that that's not an extreme use necessarily, but there's other benefits to it as well when you do that.
That's good to know because, when I'm 53 years old, you can imagine like so many things that I experienced, let's say. Cameron, we spoke about all these operations, fillers and stuff, but you're such a special doctor, the way that you get ready for these operations and how you're taking it seriously. Because when you were telling me that, your staff goes home with the patient, and then I realized, because he's only taking one person at a day. You're not taking like 10. So why don't you share, what do you do to get ready and what do you do after the fact?
Again, this gets into this like mindset of preparing for me for an event like an athlete would do, like my game for the day. So like you're saying, I really only do one surgery a day generally. And these are longer procedures. They're, these aren't 15 or 20 minutes. They're, 4 to 7 or 8 hours. And so I don't want to do that multiple times a day because when I'm in that world with that patient, I want to be at my absolute peak in flow. And it's hard to do that multiple times a day. So, I'm preparing for, my surgeries next week already right now, as an example. They're in my head. I'm visualizing through the process, the outcome, all those things. And that'll continue right up until the day of surgery for that patient. And then on that actual day, I am I call it like monk mode. It's getting in my flow state. I am getting in the hyperbaric chamber first thing in the morning for some sensory deprivation. I'm visualizing, I'm reading through usually some key things that I've saved for that person to have ready. And then after that, I'll get in the sauna and I'll do a little bit of movement and usually a short workout actually in the sauna. And that workout has evolved to be very specific to be bilateral hemispheres of my brain, stimulating the corpus callosum, the connection between them with the type of balance movements and things that I'm doing. It's very short, very intense, but it kind of gets me like activated and ready. So I'm very much like hyper-focused in flow. I'm going in there in peak performance. I know everything about the person. I have my plan set, but in the surgical setting, especially when I do a lot of fixing or revision surgeries, you have to be ready because you never know what you're going to get, right? So I'm in my peak problem solving precision mode. It's almost like an alter ego that I create a little bit when I go in there. I'm just pulling the best parts of myself into what I want to be in that surgery that day. And literally nothing else matters. I don't know what music's playing in the room. I am like so focused in on what I'm doing. But that's like highly energetically expensive to do that. And it's hard to get there repeated days in a row. Which is why my entire week prior to that, like yesterday and today for me, what I'm eating, how I'm sleeping, what my workouts are, they're centered around kind of breaking me down so that I can peak when that surgery day comes down the road. Everything has been focused on that. Once the day's over, that's where I really have to go into recovery mode because that's a huge energetic expense and I want to recover from it. Sometimes I have to do it or get to do it, I should say, 2 days in a row. And so now I'm focused on recovering from that experience, getting ready for the next day. Part of that for me is a very unique journaling practice that I do after the surgery. So Esra, we do a surgery together and afterwards there's the medical note that describes exactly what we did and how we did it and what sutures we used. And that's like, the normal postoperative note. But then to myself, I am writing notes about what I came across, what my decision-making protocols were, what unique challenges I had, what branch points of decision-making I was thinking about and what I considered, and really kind of dumping all those like cognitive thoughts out that are very specific and unique to you and your surgery. And then that's sort of like this idea where down the road, 3 or 6 months later, when we see your actual results, I can go back to that journal entry and kind of get feedback. And it's kind of like an athlete watching film after their game. They play the game, then they watch the film and give themselves feedback. I just don't get it for 3 to 6 months afterwards. So it's a really unique way for me to continually improve and get feedback on these little micro decisions I'm making as to what I'm doing.
You're a new generation surgeon. When we pay attention, when I watch very old soccer game, and you see all these guys do not do any muscle work, you can see they're very thin, they're just having a cardiovascular performance. But today, when you see they're really doing a hardcore, like a weightlifting, agility training, everything. So you're one of the new generation of athlete mindset of a surgeon, which is actually makes probably your patients much more comfortable saying like, okay, he's very focused to me. His head is not like the 2 operation before that he had a problem, because it should be very difficult to forget about if something's went wrong.
Right.
And if you jump into another surgery right after.
Even if it's not a problem, it's just everybody has unique challenges and nuances that, in my opinion, deserve that hyper focus. And, it's a lot to get there. And you hit the analogy well as far as this new age goes, because I am doing strength training and agility. Part of that is to just make me optimize as a person, and I love it, but it also, it's career longevity, it's performance in the operating room. I do jujitsu as a, sort of an outlet for me, which is a huge cognitive challenge, but also it makes me better at surgery because it puts me in very challenging mental and physical situations that I would not otherwise find. And it, increases my capacity to get better at surgery, which is very unique. When you're sort of at the top of a field already, it's very difficult to find challenges that can push you to get better. And so I try to find them from other areas of my life as well. And this is something I'm screaming from the hilltops to all of my colleagues, not just in my world, but every surgeon, because, we see this in medicine, especially in the United States, but worldwide, where these other surgeons are like badasses, essentially. They're these super high performing individuals who did a lot of work to get where they're at, but then they get to a point where they're overweight, depressed, burned out. They're shells of them, their former selves that got them there. And it's sort of like, hey, you can recover this. You can get back to it. It just takes a little discomfort, a little effort. And so, for me, that athlete's mindset helps me insulate against all those. It makes it enjoyable to do so. And I think that it could benefit a lot of my colleagues to do that as well.
Let me ask you, what would be your message to women? What not to do and what to do? Because they're going to do something. So let's give them something.
So I would say, let's just kind of go through the decades a little bit, because
sure.
We're on an aging curve, right? And in our 20s and 30s, that curve is pretty flat. And then 30s and 40s, it steepens. And then 50s and 60s, and then it starts to drop. And there's hormonal changes with that. There's a lot of things that play into that aging curve. And I am trying to push somebody back up their own aging curve. You hit on this a little bit earlier when you were talking about, not trying to make a 60-year-old look, different or whatever. That really helps for me when I'm seeing somebody's, let's say, their pictures of themselves when they were younger, right? I can look at where you're at now, Esra, where you were 10 years ago, and I can see where your curve has gone, and I can just slide you back up the curve. That makes you look and feel natural. You don't look like anything you didn't before. I'm not trying to take you off the curve to a new point. I would call that like transforming, changing you into something that you never were. And something like, say, a rhinoplasty, where you change your nose. Like, that's a transformative surgery for most people. We're not rejuvenating anything. We're changing from what it ever was. That's not the world that I live in. I live in a rejuvenating world, trying to slide back up that aging curve, right? And I say all that to say, when you're thinking about ticking forward down your aging curve, you want to be really careful to do things that don't push you off of what you look like. And so something like lip filler, and then lip filler again, and then lip filler again. That is quite literally changing you into something that you never were. You're not rejuvenating at that point. You are transforming your lips into something that never existed prior, right? So I'd be really careful about those types of things. And like I was saying before about all of these non-surgical, they're a great entry, but we have to understand that at the 10 or 15% aging mark, they kind of top out in what they can do. And so you don't want to keep pushing on them, because they will fail at best. They will make you look funny, or they will damage you. And that's that sort of big message as you're getting into it a little bit. Doing surgery when you're younger, of course, and I have to admit, I'm a surgeon. I like doing surgery. I see the benefit of it. And like we were talking about earlier, I can custom tailor it to where somebody's at in their aging curve. I can be incredibly minimally invasive and still get durable, natural results that we're after that are very appropriate for where somebody's at. So changing that sort of barrier to entry with what surgery really looks like is wildly helpful when you're in the early stages and you're kind of in that, middle position where you don't really know what to do. Doing those procedures when you're younger means that you need less surgery to get to the result that we're after. You don't have to do as much. You don't need that big open procedure like we were talking about. And you will certainly find people that that's what they want to do, but that's not the right answer, in my opinion. So you need less surgery. You always get to a better place, meaning I can get you to a better place at 45 than I can get you at 65 every single time. With less surgery, better end result. So that's a good thing. And then last but not least is when you do it younger, any procedure, it's going to last longer because, again, we're on that aging curve. The steepness is not there. The trajectory is not as steep. And so it's going to last longer. You get kind of a free decade of results before you really start to deteriorate later on, whatever age you do it. And so there's benefits to really approaching things from a more permanent mindset early on. And it doesn't have to be some crazy big procedure to get there. You can do things that are very small, very durable, very natural, and you get to enjoy them for a longer period of time. And it's sort of not in that seems too good to be true type of mindset.
Cameron, this was an amazing podcast. I know that people are going to be going crazy about it. We're going to add all your information in the show notes. Sometimes it is difficult when we translate into Turkish with AI, like, the .coms that you say. Where are you? In Seattle?
Yeah, I'm in Washington State in the northwest part of the U.S. Yep, exactly. Not in Seattle exactly, but it's same state.
Okay.
Yeah.
So thank you so much. Thank you for your time. And hopefully one day our path crosses.
Absolutely. Well, thank you for having me on the show. I appreciate it.